how best we can manage asthma. In this presentation, I will be focusing on asthma in adults and adolescents. So moving on to my slides. Hope the slides are visible to all.
Yes, it is.
So we will see the subject under 5 headings: definition, pathophysiology, clinical presentation, diagnosis, and management. So asthma is a common chronic respiratory disease affecting 1 to 18% of the population in different countries. In India, its prevalence is around 2 to 3%. It is characterized by variable symptoms and variable expiratory airflow limitation. The symptoms are usually triggered by exercise, exposure to allergen or irritant, changing weather, viral respiratory infection, etc. Then coming to the definition of asthma. Asthma is a heterogeneous disease, usually characterized by chronic airway inflammation. It is defined by the history of respiratory symptoms such as wheeze, shortness of breath, chest tightness, and cough that vary over time and in intensity, together with variable expiratory airflow limitation. So now we will briefly see the pathophysiology of asthma. So basically, there occurs a reaction to an initial and then subsequent exposure to an antigen, an inhaled antigen. So when a novel antigen is introduced to the airway of an at-risk individual, it initially becomes trapped in the mucous lining of the airway. Here it is taken up by the antigen-presenting cell, that is the dendritic cell, and the dendritic cell travel to the pulmonary lymph node. Here the antigen is presented to the naive CD4 plus T cells. And a variety of molecular signals act here, promoting the Th2 differentiation of the CD4 plus T cells. So this happens mostly. And when the host is again exposed to the same antigen, now Th2 differentiated cells, they are recruited back to the airway epithelium, releasing a wide variety of cytokines and interleukins, which acts on mast cells and eosinophils, releasing mediators of inflammation like histamine, prostaglandins, leukotrienes, and enzymes, which result in bronchial hyperresponsiveness and airway obstruction, which causes asthma symptoms. This happens mostly, but in infection with human rhinovirus and other viral infections, Th1 immune response also happen. So we all know airway of an individual is in constant contact with external environment. So the injury repair cycle continues, and like in any other chronic wound, epithelial and smooth muscle changes occur here also. So there is mucus hypersecretion, goblet cell metaplasia, subepithelial fibrosis, collagen deposition, and smooth muscle thickening, and finally remodeling of airway occur. Now we will see clinical presentations in asthma. The characteristic respiratory symptoms are cough, shortness of breath, chest tightness, and wheeze that may be temporarily related to exposure to trigger or exposure to allergens. And the cough may be productive and tenacious and difficult to expectorate. Sputum in asthma often indicates underlying airway inflammation. Cough may be the only symptom, or it can manifest with other symptoms also. And shortness of breath and chest tightness are usually due to the dynamic hyperinflation that accompanies an acute asthma attack. Always remember, no single symptom is characteristic of asthma, or no symptom is more specific for asthma, although wheeze is a useful sign. Then the symptoms are more worse at night or in the early morning. Symptoms vary over time and in intensity, usually triggered by viral infection, exercise, allergen exposure, etc. It is very important to identify comorbidities associated with asthma, like allergic rhinitis, atopic dermatitis, gastroesophageal reflux disease, obesity, etc., all of which may affect the clinical expression and severity in asthma. Now, there are certain clinical phenotypes. Certain clinical phenotypes have been described. Common ones are allergic asthma, non-allergic asthma, adult onset asthma, asthma with persistent airflow limitation, and asthma with obesity. Allergic asthma is the most easily recognized one. Patients usually give history of allergy. Symptoms often starts in childhood. Then non-allergic asthma, these patients have characteristic symptoms of asthma, but they usually do not give history of allergy. Then adult onset asthma, some patients, especially females, report with asthma for the first time in their adult life, and always rule out occupational asthma in case of adult onset asthma. Then asthma with persistent airflow limitation. We already saw that in long-standing asthma, airway remodeling happened and airflow limitation became persistent. Then finally, asthma with obesity. Some obese patients with asthma, they have predominant respiratory symptoms with little underlying lung inflammation. So these are the common clinical phenotypes of asthma. Then we will see the diagnosis. Asthma is a clinical diagnosis supported by documented evidence of variable expiratory airflow limitation. The characteristic history, we already saw symptoms like cough, chest tightness, wheeze, and shortness of breath. Patient may give history of allergic rhinitis, atopic dermatitis, etc. And there will be a family history suggestive of asthma or allergy. Then physical examination is often unremarkable. All you can get is an expiratory rhonche on auscultation. Sometimes this may be heard only on forced exhalation. And in severe asthma, rhonche may not be heard due to severely reduced airflow in lungs. This is known as silent chest. And remember, crepitations and inspiratory wheeze are not usually features of asthma. Then the third thing is the lung function test to document variable expiratory airflow limitation. So now we have a patient with characteristic symptoms of asthma. So we need to confirm variable expiratory airflow limitation in these patients. We usually use spirometry or peak expiratory flow meter to document expiratory airflow limitation. FEV1, that is the forced expiratory volume in first second, is reduced in all obstructive lung diseases, whereas the ratio of FEV1 to FVC, that is forced expiratory volume in first second to forced vital capacity, is reduced compared with the lower limit of normal in case of expiratory airflow limitation. So once we document expiratory airflow limitation in spirometry, we need to confirm variability, that is positive bronchodilator responsiveness. Variability refers to an improvement or deterioration in lung function as well as clinical symptoms in response to a bronchodilator or over time spontaneously. Positive bronchodilator responsiveness, previously it was known as reversibility. It is the increase in forced FEV1, that is forced expiratory volume in first second, more than 12% and 200 ml from baseline after a rapid acting bronchodilator inhalation like salbutamol 200 to 400 microgram or equivalent. Then a positive bronchodilator responsiveness is consistent with the diagnosis of asthma in a patient with characteristic respiratory symptom. And if spirometry is not available, we can go for peak expiratory flow meter, which is less sensitive compared to spirometer, and excessive variability in twice daily peak expiratory flow over 2 weeks. That is, an average daily diurnal PF variability more than 10% is consistent with the diagnosis of asthma in a patient with characteristic symptom. We also have other tests to document variable expiratory airflow limitation like exercise challenge test, bronchial challenge test, but which are these tests are rarely used in clinical practice. If possible, evidence of variable expiratory airflow limitation should be documented before starting treatment. This is because once you start treatment, the reversibility or the responsiveness decreases as lung function improves. Or if the patient is already on treatment, you can stop temporarily. You can temporarily stop treatment for diagnostic purpose also. You can always refer the patient with characteristic asthma symptom to a nearby Schwarz clinic to do spirometry and confirm the diagnosis. So this is the spirometry image showing positive bronchodilator responsiveness. The red line in the flow volume loop indicates a positive response. Here the FEV1 has increased up to 320 ml and 21% from baseline after 400 micrograms salbutamol inhalation. Same spirometry showing post-bronchodilator responsiveness. So why it is important to diagnose asthma before starting treatment? We all know that asthma is a heterogeneous disease, so many other cardiorespiratory conditions can mimic asthma, and also the drugs used in asthma, they have got their own side effects. So it is very important to avoid unnecessary treatment or over treatment, and also to avoid missing the other important diagnosis also. So coming to the differential diagnosis, I already said no single symptom is more significant for asthma. So in younger age group presenting with chronic respiratory symptoms, always rule out chronic upper airway cough syndrome, inducible laryngeal obstruction, chronic diseases like bronchiectasis, and also congenital heart disease. In 40 plus age group, the differential diagnosis should include COPD, bronchiectasis, medication-related cough, cardiac failure, pulmonary, vascular, and parenchymal disorders. But in all age group presenting with chronic cough, always rule out tuberculosis. Then a few subtypes, a few words about subtypes of asthma. First one is occupational asthma. Usually asthma acquired in the workplace is frequently missed. The symptoms may be induced or commonly aggravated by workplace exposure, and occupational rhinitis may proceed by up to 1 year, and symptoms may improve when the patients are away from work, and early diagnosis is a must in this case as persistent exposure is often associated with worse outcomes. Next subtype is aspirin exacerbated respiratory disease. Here, an acute asthma attack developed following ingestion of aspirin or NSAIDs, usually associated with corneal irritation, rhinitis, and cutaneous flushing. Diagnosis is by characteristic history, and of course, theoretically, challenge tests are there. Next subtype is allergic bronchopulmonary aspergillosis. ABPA is a complex disease usually characterized by recurrent episodes of wheezing and fleeting pulmonary opacities. It is due to hypersensitivity to inhaled Aspergillus fumigatus. It is diagnosed by a criteria involving serum IgE, hypersensitivity to Aspergillus, and also radiology. So now let us discuss management of asthma. So with respect to the management, the guidelines we need to know is the JINA guideline. JINA stands for Global Initiative for Asthma. JINA was formed in 1993, and ever since then they have made recommendations for the management of asthma. Our discussion will be centered around 2022 updates of JINA. So long-term goals. When it comes to the treatment of asthma, JINA says that there are certain long-term goals in asthma management. So when you treat a patient with asthma, you want the patient to achieve good control of symptoms and to maintain normal activity level, And you also want to minimize the risk of asthma-related death exacerbations. You want to minimize persistent airflow limitation and also to reduce side effect related to asthma medications. So these are the long-term goals of asthma management. Now we will see the medication options available for asthma treatment. You can broadly categorize asthma medications into three groups. First one is the controller medications. Second is the reliever medication. And third is add-on therapies for patients with severe asthma. So controller medications, they are also known as the maintenance medications. They are used to control underlying lung inflammation and to prevent future exacerbations or flare-ups. As per JINA, you can have an inhaled corticosteroid, that is ICS, or a combination of an ICS and a long-acting beta-2 agonist as controllers, an ICS or a combination of ICS LABA. Then reliever medications, also known as rescue medications, they are used to treat a particular asthma attack. Then JINA recommends to use either an inhaled corticosteroid, long-acting beta-2 agonist like formoterol, that is ICS formoterol combination, or a short-acting beta-2 agonist like salbutamol as relievers. Then add-on therapies. These are used for patients who are refractory to high-dose treatment with steroids and LABA. Add-on therapies include long-acting muscarinic antagonists like thiotropium, then oral corticosteroids, and also biologicals like immunoglobulins. Biologicals like anti-IgE, immunoglobulin 5 inhibitor like omalizumab, etc. Then a few words about leukotriene receptor antagonists that we use frequently for the treatment of asthma. JINA says these are less effective than inhaled corticosteroids in the management of asthma. So when giving leukotriene receptor antagonists, the risk-benefit ratio should be assessed, and always counsel the patient about neuropsychiatric events associated with the long-term use of leukotriene receptor modifiers. Unfortunately, oral salbutamol and sustained release theophylline have weak efficacy in asthma treatment, and they have also got a higher side effect profile. We already said that different IC inhaled corticosteroid combinations are there. The commonly used one are budesonide formoterol, beclomethasone formoterol, fluticasone formoterol, etc. We are having different inhalers available in different formulations like dry powder inhalers, meter dose inhalers, breath actuated devices, etc. Inhaled corticosteroids, different options are available, as well as they come in different doses also, like low dose, medium dose, and high dose. This is very important to understand the stepwise management of asthma recommended by JINA. So the commonly used one, budesonide. Budesonide, the low dose is 200 to 400 microgram daily. Medium dose is 400 to 800 microgram daily, and high dose is more than 800 microgram daily. And for fluticasone, it is 100 to 250 low dose. Medium dose is more than 250 to 500, and high dose is 500 microgram daily. So dose differs for individual agents. Then out of all these, maximum evidence for treatment benefit and safety is for budesonide formoterol combination. So now we discuss the treatment per se for judicial management of asthma. JINA recommends stepwise management for asthma. Then once you assess the patient and confirm the diagnosis of asthma, you can have two approaches. JINA describes these two approaches as two tracks, track 1 and track 2. You can have either of these tracks, but track 1 is always the preferred track, and track 2 is an alternative track used only in certain special situations. So both in track 1 and track 2, there is a reliever drug, also a controller drug. Now we will see each track separately. So Here, track 1. Track 1 is always the preferred track. Here, the patients are grouped into 5 groups, 5 categories based on the severity and frequency of asthma symptoms. And in all these 5 groups, the reliever, that is the rescue medication used, is an as needed low dose ICS inhaled corticosteroid formoterol combination. And the controlled drug differs in each 5 steps. So step 1 and 2, they are grouped together because they have the same treatment. Step 1 means, or group 1 means, patients are having symptoms less than 2 times per month. Step 2, more than 2 times per month. But generally, they are having symptoms less than 4 to 5 days per week. And in step 3, patients are having symptoms on most days, and patient wakes up from sleep at least once. In step 4, in addition to step 3, patients are having a low lung function as evidenced by spirometry. And whatever is not controlled in step 5 is categorized in step 4 is categorized in step 5. So in step 1 to 2, you don't need to give a daily maintenance. Here, an as needed low dose ICS formoterol that is used as a reliever itself acts as a maintenance to control underlying lung inflammation and to prevent future exacerbations. So we don't need a daily inhalation therapy in step 1 to 2 here. In step 3, we need to, from step 3 onwards, we need to give a daily maintenance therapy. So in step 3, a low dose ICS formoterol is given as maintenance daily along with an as needed low dose ICS formoterol reliever. So in step 4, medium dose ICS, here also daily maintenance is required. A medium dose ICS formoterol combination is used for daily maintenance along with the low dose ICS formoterol as reliever. Then in step 5, that is if the patient is refractory to treatment in step 4, you can consider high dose ICS inhaled corticosteroid formoterol combination. Along with that, we can have add-ons like long-acting muscarinic antagonists like thiotropium, and also all these biologic agents like anti-IG, like omalizumab, etc. So the reliever is as needed low dose ICS formoterol, and the maintenance therapy differs in each step depending on the clinical symptom, severity and frequency of symptoms. I hope that is clear. Then we will see track 2. Track 2 is less preferred than track 1. Here the major difference is the reliever used here is an as needed short-acting beta-2 agonist like salbutamol. Here also patients are grouped into 5 groups depending upon clinical symptom. Step 1, symptoms less than twice a month. Step 2, symptoms twice a month or more but less than 4 to 5 days a week. Step 3, like in track 1, symptoms most days, wakes up from sleep due to asthma once a week or more. Then in step 4, like in track 1, along with the step 3 symptoms, patient has low lung function, and whatever is not controlled in step 4 comes under step 5. So in track 2, step 1, patient needs to take an inhaled corticosteroid whenever SABA is taken. So whenever the patient is using a salbutamol-like inhaler, he needs to take an ICS containing drug. This ICS acts as a maintenance drug to control lung inflammation. From step 2 onwards, in track 2, from step 2 onwards, you need to give a low daily maintenance therapy. Here in step 2, a low dose ICS is given as maintenance, low dose inhaled corticosteroid. Then in step 3, a low dose ICS LABA combination is given as maintenance along with an as needed short-acting beta-2 agonist. In step 4, you can use a medium to high dose ICS LABA combination for daily maintenance along with a short-acting inhaler like salbutamol. Then in step 5, add-ons like LAMA and also biologicals like anti-IL-5, anti-IG, etc. So the point is, never ever use salbutamol alone in asthma. You always need to give an ICS containing inhaler so as to prevent future exacerbations and flare-ups. So why track 2 is less preferred? Because evidences have shown that use of SABA, that is short-acting beta-2 agonist as a reliever, increases the risk of exacerbations. As well as we all know that when salbutamol or SABA is offered, it offers the patient quick relief. So patients become less adherent to maintains inhaled corticosteroid or maintenance ICS LABA combination, finally ends up in using salbutamol alone and ends up in having frequent exacerbation. So imagine a patient comes to you with daily asthma symptoms, wakes from sleep at least once a week, and has an documented evidence of low lung function as evidenced by spirometry. So clearly he is in step 4. So you need to give a medium dose ICS formoterol maintenance as well as a low dose ICS formoterol for reliever. This does not mean that this patient stays in step 4 for lifelong. He might come down to step 3, or he may worsen and go into step 5. So it is always a personalized approach. Treatment is not same for each patient every time. It is always a personalized approach assessing the symptom severity and frequency. Once symptom control has been achieved and it is maintained for 2 to 3 months, consider stepping down the treatment to find the best minimum possible dose for maintaining good symptom control and preventing exacerbations. So a few words about other therapies. We have allergic immunotherapy, commonly used as subcutaneous immunotherapy and sublingual immunotherapy. Here, clinically relevant allergens are introduced in progressively higher doses to induce desensitization. Then regarding vaccination, moderate to severe asthma patients should receive influenza vaccine yearly ideally. Pneumococcal vaccine is not routinely recommended as there is insufficient evidence. Then COVID-19 and influenza vaccine may be given on same day also. It is a bronchial thermoplasty is a potential treatment option by using radio frequency ablation of the airways. Then vitamin D, low serum levels of vitamin D are associated with impaired lung function, higher frequency of exacerbations, and reduced corticosteroid response. So coming to the non-pharmacological management, which includes cessation of smoking and environmental tobacco smoke exposure. Always encourage the patient to do physical activity, ask to avoid occupational exposure. Then one important thing is avoidance of medications that may make asthma worse. Always ask about asthma before prescribing NSAIDs and advise patient to stop using them if asthma worsens. Aspirin and NSAIDs are not generally contraindicated unless there is a history of previous reaction to these agents. Then advice about healthy diet, avoidance of indoor allergens, outdoor pollution, weight reduction, breathing exercise. These are all very important in the management of asthma. So a few words about asthma in pregnancy. Symptoms may change in pregnancy, and this may be due to hormonal change or mechanical change due to the growing uterus, and also cessation of asthma medication due to concerns by mother or relatives. And exacerbations are very common from second trimester onwards. But evidences have shown that active management of asthma in pregnancy outweighs the potential risk related to asthma medications. Now coming to indications for referral for expert advice. In certain situations, you have to refer the patient for expert advice. Like if you have difficulty in confirming the diagnosis of asthma, like in situations like patient has symptoms of chronic infections or features suggesting a cardiac or other non-pulmonary cause, or diagnosis is unclear even after a trial of therapy with ICS, or in case of a suspected occupational asthma, always refer for confirmatory testing and identification of the sensitizing agent. Or if the patient is having persistent or severely uncontrolled asthma or frequent exacerbations, you need to refer the patient to higher center if there is any risk factors for asthma related death. like a near fatal asthma attack, that is the history of ICU admission or mechanical ventilation for asthma at any time in the past, or if there is a history of anaphylaxis or food allergy in a patient with asthma. You also need to refer the patient for expert opinion if there is evidence of significant treatment-related side effect, and also if there are symptoms suggesting complications of asthma or subtypes of asthma. For completion's sake, we'll also go quickly through the management of exacerbation in a primary care facility. So if a patient comes with asthma, assess the patient and categorize the patient clinically into mild or moderate exacerbation and severe exacerbation. In mild to moderate exacerbation, patient can talk in phrases and patient is not agitated, respiratory rate is increased, there is no use of accessory muscles of respiration, pulse rate is increased, comes around 100 to 120 beats per minute, saturation is between 90 to 95% approximately. In this situation, start treatment immediately using short-acting beta-2 agonists like salbutamol. You can give either through a nebulizer or a meter dose inhaler depending on the clinical situation. Give salbutamol every 20 minutes for 1 hour. You can give controlled oxygen if available, targeting an oxygen saturation of 93 to 95% in adults and adolescents. And also you can give prednisolone orally 40 milligrams. And if the patient is not tolerating orally, intravenous steroids can also be given. Then assess the patient at 1 hour or earlier if clinically indicated. And if the patient is improving, that is, the patient has symptomatic relief, respiratory rate is coming down, and oxygen saturation is improving, that's more than 94% in room air, you can send the patient home. And at discharge, arrange a reliever, that is, an as needed reliever can be arranged. Also, if the patient is not on controller treatment, start a controller drug. If he is already on treatment, step up the controller for short term. You can give prednisolone, short course steroids orally. Usually, prednisolone 40 milligrams for 5 to 7 days is recommended in adults. Then arrange the follow-up visit within 2 to 7 days. So, if the exacerbation is severe, that is, patient talks in words, patient is agitated, respiratory rate is more than 30, there is use of accessory muscles of respiration, pulse rate is more than 120 beats per minute, saturation is less than 90%. You need to refer the patient to an acute care facility. And while waiting, you can give short-acting beta-2 agonist via nebulization, then oxygen, and also systemic corticosteroids. So this is about management of an asthma attack in primary care facility. So then a few words about asthma COPD overlap. We discussed asthma, and COPD by definition is a common preventable and treatable disease that is characterized by persistent symptoms and airflow limitation, that is due to airway or alveolar abnormality, usually caused by exposure to noxious particles and gases and influenced by host factors. So, asthma COPD overlap. There is an entity called asthma COPD overlap, and this is used to collectively describe patients who have persistent airflow limitation together with clinical features that are consistent with both asthma and COPD. So, if the patients have features of both asthma and COPD, that is, symptoms are intermittent or episodic, symptoms may have started before age of 40, patients may have history of smoking or exposure to other noxious agents, and spirometry showing persistent airflow limitation, reversibility may not be there. In this situation, never give bronchodilators alone. Patient always needs an ICS containing treatment in case of features of both asthma and COPD. So an ICS containing treatment is essential in case of asthma COPD overlap. A few words about asthma and COVID-19. Patients with evidences have shown that patients with well-controlled asthma, they are not at increased risk of acquiring severe COVID-19 or COVID-19 related death. Then advised to continue taking their prescribed asthma medication while having an episode or infection with COVID-19, including inhaled corticosteroid. Avoid use of nebulizers if possible, as it increases transmission. Then avoid performing spirometry in suspected or confirmed case. Then follow infection control measures if aerosol generating procedure is needed. Asthma patients should be up to date with COVID-19 vaccination, including booster dose. So to conclude, asthma is a heterogeneous disease characterized by chronic airway inflammation. It is important to confirm the diagnosis of asthma before starting treatment, and always personalized treatment is offered, and stepwise management is advised by JINA depending upon the symptom severity and frequency. And never give SABA alone. That is, short-acting beta-2 agonist like salbutamol alone treatment is no longer recommended by JINA guideline. And all adults and adolescents with asthma should receive an inhaled corticosteroid containing maintenance therapy. That's all about asthma. Thank you for the patient listening.